Next up is Ilkka Kunnamo. Name even close to right, from Duodecim, which is part of the overall Finnish Medical Society. He's going to talk, the title is Doctor 2030, a life coach or a robot. But really what he's going to talk about is the role, the emerging role in the future of how electronic medical records are changing and the role in the future of care, decision support and care pathways. So please take it away. Grab the clicker for me.
Okay, thank you very much for inviting me. I'm a medical doctor, a clinical decision support developer, and I will give an overview how digital health can be implemented by the integration of data and knowledge. Let me first introduce you two people. One is Anne, and the other is Tim. Anne is 35 years and Tim is 55 years. They don't know each other. They have only one thing in common. Both have a cholesterol level of 6.8, which is moderately high according to our reference values. So the clinician meeting these two people might think, what's the evidence for treating high cholesterol with a statin? That's a drug that is commonly prescribed for high cholesterol. So let's see, if we look at the evidence, we read the systematic reviews, so we find that irrespective of the age of the patient or any underlying risk, the relative effect of a statin means that there is about 25% reduction of risk for stroke, myocardial infarction, or death. So how about, would you treat both of these people with a statin? Of course, we need to look at the absolute risk for any of those events. And there we need some more data. Actually, we can use about 9 risk factors to estimate the risk of such an event. If we first look at Anne, we see that actually all the risk factor levels are very low, and her risk is 0.7% in 10 years. That means that fewer than 1 out of 140 people like Anne would get any of those events, stroke or infarction, in the next 10 years. And that would mean that if we would give statins to people like Anne, we would need to give the drug to 600 people to make one of them avoid such an event. So we say that the number needed to treat is 600. Okay, let's look at Tim. Tim's risk is 61%. He has many risk factors: high blood pressure, diabetes, he's a smoker, overweight, and so on. More than 1 out of 2 people like Tim would develop an event in 10 years. And that means that only 6 people like Tim need to be treated with a statin to benefit. So that means that the number needed to treat is 6. And that's actually a very good effect for any healthcare intervention. So, what healthcare is about? Steven Spielberg told that us in year 2000 in the movie Minority Report. Those who saw this movie know that Tom Cruise prevented crimes by predicting a crime, then intervening very quickly and prevented the crime before it was committed. That's all about healthcare. We want to predict and we want to prevent. And that can take place if we combine data and knowledge. Today, patient data is in silos. It's in electronic health records, personal health records, even glucometers, other devices, and those vendors are jealous. They don't want to share the data with anyone. The data is in silos. The first condition to make digital health work is to put the data in one place. Data recorded by healthcare professionals, data recorded by patients by themselves. The majority of data will be recorded by patients by themselves in the future, specifically when they have devices and wearables that record everything. Now it's called body hacking, but it will be the mainstream in the future. So it will dramatically change the picture. Now the data is available for everybody, and all EHRs and PHRs, they will become apps that can store the data, that can use the data from this common data store. And even every mobile phone app for a single purpose can do the same. The world will be full of health apps. And how to integrate them with the data. There is a very interesting, I would say, hot standard called FHIR, which has already been implemented by many companies. You can go to this App Gallery webpage, and you can see how nicely patient data can be visualized by these tools. And not only visualized, but connected and integrated with knowledge. Here is a little bit the bigger picture. On the left side, you have data of the individual patient, but you also have history data of all patients. You have big data. On the right side, you have all medical knowledge from different sources. An ideal situation would be that there would be one interface to the data and one interface to the knowledge. And then there would be a secure gateway where you can exchange the data. And all the apps could connect to this gateway. Actually, this has already happened in Estonia and will happen in Finland, where we have what we call an X-road. And also Finland and Estonia, they have a national archive where all patient record data is stored. And also PHR data will be there. This is one example how to integrate data knowledge on one screen. Here we can see the diagnosis of the patient, the medications, relevant lab test results. For the diagnosis, which we have clicked on the left, we can see decision support reminders for that diagnosis and guideline links for that diagnosis. If we click another diagnosis, the whole view will change. Now it will show the data for that diagnosis and also the knowledge. This is such a simple modeling study where 4 minutes were saved at each patient encounter by using such a tool, and 57 mouse clicks were avoided. There is another example, the comprehensive medication review, all guidance on drug therapy and medication safety on one page for the individual patient, just by combining all the data and all the knowledge we have on drugs. So, today, on the right side, we have about 100,000 different data elements. If we sum up all diagnoses, all drugs, all procedures, all lab tests, that makes about 100,000. In the future, we will have millions or even billions when we have the genome data, we have the protein data, we have the gene expressions. So the amount of data from the individual patient will explode. But so will knowledge. Currently, we have about 25 million citations in the PubMed database. Year 2012, for the first time, the number of new medical publications exceeded 1 million in the year. And even more, if you look at the genome data, the explosion started when the human genome was sequenced. And after that, the doubling rate of genome data has been about 18 months. Not only about humans, but all other organisms like bacteria, parasites, also their DNA has been analyzed. So, genome data might already be important for Anne or Tim. Here is a study which used the data from all cholesterol trials in the past. And the genome of many of the participants was analyzed, and then the genetic risk was determined. And we can see that those red columns are the benefit of statins for people with high genetic risk, and the green bars is the benefit for patients with low genetic risk. And note that all the other risk factors were the same for these people. So you can imagine that for people like Anne or Tim, this might make a difference if you knew their genome. We need some special tools. We need, in the middle, a database of validated gene associations, which knows, for instance, how the different combination of genes lower or increase cardiovascular risk, how they modify the effect of drugs, or how they determine some conditions. And on the left side, we need a query interface to pose a clinical question. It's no use of giving the clinician 40,000 lab test results. That means all the genes of the patient. We need to make a query to these gene associations when we have a clinical question where we need that information. And that's what we can do with a clinical decision support system, which you can see on the left. So now let's start building a big picture. The patient in the middle is recording data, professionals are recording data, and we will have coded data in the database. We analyze the data with clinical decision support tools. We identify potential for health benefit that consists of individual interventions we can do for the patient. We did this in Finland for a population of 16,000 people using 100 clinical decision support rules, and we found 400 people whose blood pressure should be treated. We found 58 people who haven't visited at all for their diabetes. We found more than 1,000 people whose drug dosing should be checked because they had renal dysfunction. And we found 28 people whose drug should be stopped because they had severe renal dysfunction. So we can identify the benefits, and we want to make a care plan. And at this stage, actually, we would like to know the amount of benefit, the balance of risks, balance of benefits and harms we get from each treatment before we can make a treatment plan. And this is how medical knowledge is and will be organized. This is called a summary of findings table. In the middle, it describes how many people out of 100 would get an event, or for instance, in this case, would be helped by a drug, would be helped without a drug in a certain time period. On the right side, you can see how many people would get the benefit if they would be using the drug. Now, when we want personalized and individualized care, we want to estimate the baseline risk for the individual. What's the likelihood of Tim benefiting from this drug? This is personalized medicine when we can estimate the baseline risk. So once we do that, we can also tell the benefits and risks to the patient, and then the patient can decide which are the important outcomes he or she wants to pursue, which are the targets he or she wants to meet, and which are the interventions he or she wants. These are the important choices that the patient has to make. And once they do it, then we can prioritize. The population can be listed and sorted by care benefit. We can analyze the care gap in the whole population. For each patient, we can put the most effective interventions on top. And finally, people choose from those interventions which they want to implement. So, from the society viewpoint, there are high-impact interventions where the outcome is important, a prevalent condition, the net benefit is large, and the care gap is large. These are the points where we should pay attention to, and these are the patients we should care for. High-value intervention, a cost-effective intervention, is something where also the cost per quality is low, so that we can obtain a lot of benefit with rather cheap interventions. So, the whole medical knowledge needs to be reorganized. And this is happening by organizations and companies, which actually all healthcare companies should communicate with to get the evidence in place. Here are just examples. There are many other such companies and organizations. This is just one example. The PICO is the element of the clinical question: patient group, intervention, comparator and outcome. And there is a PICO ontology developed by the Cochrane collaboration, which will actually organize all research results in this way. So finally, we can make the care plan, and when it's coded, we can automatically provide tools for the patients for self-management. They can make an online health check, and they can receive online health coaching for their problems. Maybe Tim didn't want a cholesterol drug at all. He wanted to make a lifestyle change and opted for that. So, but there are situations where we also need the professionals on the right side. And then we need some tools to make the professionals work effectively. We saw that we can use clinical decision support for care planning of one patient. We need enterprise resource planning software for planning the care of the whole population. Here is a care plan for an individual patient. It has some time points. It's based on evidence. It has been agreed by the patient and the clinician. If the patient has many conditions, there will be many things he has to do. So we need to coordinate. We need to merge the encounters to a care plan, a coordinated care plan for the individual. And once we have those coordinated care plans for every individual and every service there is coded, so then we can feed those services and codes to the resource planning software, which puts all these things nicely in the workflow of the clinicians, and all the bookings of the resources are made automatically. So you can see that at the bottom there is a arrow from resources to the care plan, that the resources are taken into account when the care plan is made. On the right side, there is the big data that is gathered all the time that will also influence the future decisions. So we will be able to build a learning healthcare system where every data item in the electronic health record contributes to the body of medical knowledge, and where every series of actions in the electronic health record is actually recorded and analyzed to understand workflows and to find shortcuts. So finally, we can obtain health for all. It's a political choice for the society, but it's a question of values and preferences for the individual, enabled by digitalization of healthcare via integration of data and knowledge. Thank you.